If your LDL is 253 after a heart attack and a stent, this is not just high cholesterol, this is a medical emergency risk signal. ApoB of 207 and Lipo A is 440 on this patient. That means the arteries are being attacked from two directions. This is the kind of cholesterol report where lifestyle alone is not enough. A normal HDL does not cancel out, or even a high HDL doesn't cancel out a dangerously high LDL, ApoB and lipoprotein A. And if you already have heart attack history, your cholesterol goal is not normal, it must be aggressively low. Hello everyone, Dr. PK. I am talking about a case here, a real case. I'm seeing this patient for the first time. I just saw the patient recently, so I wanted to discuss and bring this to your attention, what's going on. Because many people look at their cholesterol report and think, oh, my HDL is high, it must be okay, I must be fine. Because this can be dangerously misleading, high HDL or normal HDL, with the background information of high LDL and high lipoprotein A and ApoB. So this patient had a heart attack several years ago, had coronary artery stent placed, but later became non-compliant with medication, almost like 2 years. And this guy used to be an athlete. He used to play with a minor league baseball. And he has very active lifestyle right now. But he has been non-compliant with medication. When I saw him first time and I look at his numbers, I'm just like, wow, there's got to be eye-opener, at least for me, that he is still alive. And total cholesterol 333, LDL 253, non-HDL cholesterol 273, HDL 60, ApoB 207. It should be 90 or less. And lipoprotein, I think it should be 75 or less. And his was 440. His dad died of heart attack. This is not an ordinary cholesterol elevation. This is a very high risk cardiovascular disease. Because one sometimes has already had a heart attack or a stent, we are no longer talking about prevention only. We are talking about secondary prevention, means talking about preventing the next heart attack. This case is high risk because he has a clinical atherosclerotic cardiovascular disease, ASCVD. Means high cholesterol plaque has already caused damage in the artery, leading to heart attack and need for a stent. In this setting, LDL of 253 is extremely dangerous. For very high risk ASCVD patient, current expert guideline is aggressive LDL loading, often targeting LDL below 55, according to latest cardiovascular American Cardiology Association's recommendation, American Heart Association recommendation, or at least 50% reduction, especially when patient has prior MI or stent history. And so he's roughly 5 times higher than where it would ideally, we would ideally want it to be. That means the arteries are being exposed to constant stream of cholesterol particles that can keep feeding plaque. Now let's talk about the ApoB. ApoB is one of the most important numbers in this report. LDL cholesterol tells us how much cholesterol is inside LDL particle. But ApoB tells us the number of dangerous particles floating in the blood. Think of this way, LDL cholesterol is like the cargo. ApoB is like the number of delivery trucks carrying that cargo into an arterial wall. And ApoB of 207 is extremely high. This means the bloodstream is loaded with very high number of plaque-forming particles. We call them atherogenic particles. Even if someone says my HDL is 60, that does not erase the danger of ApoB of 207. HDL may protect in some context, but it cannot neutralize this many artery damaging particles. Now, lipoprotein A 440, that's a genetic risk factor. His father had a heart attack. He died from it. 440 is very high and is genetically driven cholesterol particle, lipoprotein A. It behaves like LDL, but is more inflammatory and more clot promoting. And high lipoprotein A is considered a causal risk factor for atherosclerotic cardiovascular disease and aortic valve stenosis. Very high lipoprotein A levels above 180 milligram per deciliter or 430 nanomole per liter may carry lifetime cardiovascular risk similar to untreated familial hypercholesterolemia. So this guy is 440 nanomole, that is extremely high. So he has inherited cholesterol risk. So, and diet alone cannot fix it. That's why lipoprotein A should be screened. Non-HDL number is 273. That's another powerful marker. It includes all the bad cholesterol particle, LDL, VLDL, remnants, and the other ApoB containing particles. And non-HDL cholesterol of 273 is severely elevated. In patient with previous heart attack and a stent, yeah. So this number tells us the total burden of atherogenic particles very high. LDL is bad enough here, but non-HDL confirmed the entire cholesterol particle burden is dangerous. So I started rosuvastatin 40 milligram, first major treatment, high intensity statin. The goal is to dramatically reduce LDL cholesterol and stabilize plaque. And statins do more than lowering LDL. It reduces inflammation inside plaque and helps plaque less likely to rupture. And someone with the prior MI and stent, a high intensity statin therapy is the cornerstone for secondary prevention. Okay, so after a heart attack, statin are not just optional cholesterol pills, they are plaque stabilizing, life protecting therapy. And I started with aspirin 81 milligram. Aspirin 181 milligram is commonly used for secondary prevention after heart attack or coronary stenting. The purpose is to reduce platelet clotting. So someone with a history of a stent, clot prevention is just as important as cholesterol control. And I started on beta blocker, restarted him actually, he used to be on it. So after heart attack, beta blocker is used to reduce heart workload, control heart rate, control blood pressure, reduce angina, help protect patients with reduced heart function. So 2023 chronic coronary artery guideline notes that long-term beta blocker therapy is not automatically needed in everybody for a stable patient after MI unless there is a specific reason, and that is this person has hypertension. He doesn't have angina, but beta blocker is also known to reduce recurrent heart attack. And why I also added in Farxiga? So commonly used in patients with type 2 diabetes, heart failure, or chronic kidney disease, depending on the indication. He has a coronary artery disease, and Farxiga makes sense because of cardiometabolic risk. Farxiga is not a cholesterol-lowering medication. It helps through different pathways: glucose control, kidney protection, heart failure benefits. And other option for him is PCSK9 inhibitor injection and ezetimibe and bempedoic acid. So I'll follow up with him in few months, 6 months, and reassess his whole situation. Lifestyle factor still matters, but it's not enough alone. Thank you for watching. I hope you learned something from this video. Let me know what you think about this case.